Welcome to the Funnel Effect. Today we are really diving deep, right into the heart of cardiovascular medicine, you could say. We're focusing on the absolute latest advances in imaging techniques, the ones used to really understand and manage atherosclerotic plaques. This is like advanced detective work. We're going beyond just seeing a blockage, trying to uncover that hidden future risk buried inside the artery wall itself. And our guide for this deep dive is a really comprehensive clinical review. It's titled Advances in Coronary Imaging of Atherosclerotic Plaques, and it was published in Eurointervention in 2025. The authors are a real powerhouse team. Hector M. Garcia, Jorge Cel Sanchez, Natalia Pina Echeverria, Pablo J. Blanco, Cristos Borantes, and Fernando Alfonso. Quite the lineup.
It really is. And this review couldn't be more timely. It really forces us to grapple with a central challenge in cardiology today, which is that most heart attacks, these acute myocardial infarctions or AMIs, they aren't actually caused by the tightest blockages you see on an angiogram. No, they're typically caused by the rupture of what we call a high-risk entity, the fibrotheroma. And this plaque might not have been causing much flow limitation at all, just moments before it breaks open. So our goal today, our mission, if you will, is to get a solid understanding of how these incredibly sophisticated imaging tools, both the non-invasive ones and the invasive, almost microscopic ones, give us these unique micro-level views of how plaques evolve. Because it's this knowledge, this detailed insight, that lets us better pinpoint those truly high-risk plaques. And maybe even more importantly, lets us see if our treatments, whether it's medication or an intervention like a stent, are actually working to stabilize or even shrink the disease at the plaque level.
Okay, let's start unpacking the specialized toolbox then. To really analyze the disease, we need the right terms. So before we jump into the specific technologies, what exactly are we measuring when we talk about
That's the plaque burden. Simple concept, really crucial metric. It's just the area taken up by plaque divided by the total area of the vessel at that cross-section. It's usually reported as a percentage.
So if you hear 80% plaque burden,
that means 80% of that vessel's cross-sectional area is filled with plaque. That's a very high burden. It tells us about the sheer physical extent of the disease in that segment.
Right. Okay, so with that foundation, let's take inventory of the toolbox. Starting with the non-invasive approach, the screening champion.
Yeah, on the non-invasive side, the main player is coronary computed tomography angiography, or CCTA. It's really become the go-to screening tool. Why? Because it can map out the entire coronary tree, all the heart arteries, quickly and without needing catheters inside the body. It's fantastic for getting that big picture view, assessing overall plaque accumulation, checking stenosis severity. Especially useful when you're managing patients with, say, chronic stable chest pain.
Sounds like the ideal first step. But the source material immediately flags its limitations, especially for what we're focused on today, characterizing vulnerability, the dangerous stuff.
Precisely. Because CCTA gives you a wide-angle snapshot, not a high-res zoom-in. Its resolution, while good, just can't compete with the invasive techniques when you need microscopic detail about the plaque's composition. But probably the bigger issue for CCTA is calcium. CT uses X-rays, right? And dense calcium really interferes with X-rays. It creates what we call blooming artifacts.
Blooming, like a flower.
Sort of, but less pleasant. The calcium is so dense that it scatters the X-rays excessively. This makes the calcium deposit appear much larger on the image than it actually is. It blooms outwards.
So it exaggerates the problem.
It can, yes. It leads to an overestimation of how severe the narrowing is, and more critically, it obscures our view. It makes it hard to accurately measure the true size of the remaining lumen right next to that calcium. So CCTA gives us the extent of disease pretty well, but for those granular details about what the plaque is actually made of, is it fatty, is it stable, for vulnerability, you really have to go invasive.
Which brings us inside the arteries.
Yeah.
The two big players here are IVUS and OCT. And the fundamental difference is the physics, right? Sound versus light.
Exactly. And understanding that difference is key to understanding their strengths and weaknesses, their trade-offs. Intravascular ultrasound, IVUS, uses high-frequency sound waves. Its resolution is pretty decent, around 150 micrometers or a meter. Yeah. Because sound penetrates tissue well, IVUS gives you a great look deep into the vessel wall. Excellent for quantifying that overall plaque burden we talked about, seeing the vessel boundaries clearly. And it's good at detecting things like calcium and fibrous tissue. It's really the workhorse for measuring plaque volume.
Okay, volume and depth with sound. And OCT.
Yeah. OCT, optical coherence tomography, uses near-infrared light. Now, light has a much, much shorter wavelength than ultrasound, and that means its resolution is drastically better. We're talking down to about 15 micrometers. 15. That is absolutely unsurpassed in coronary imaging.
Wow, that's a tenfold difference.
It is. Think of it like having a pathologist's microscope, but you've brought it right inside the living artery. The trade-off: penetration. Light doesn't travel through fatty tissue or really dense calcium as easily as sound does. So OCT's depth of view is more limited compared to IVUS, but where it can see, its focus is incredibly sharp, razor sharp.
Okay, so IVUS, big picture volume with sound. OCT,
Yeah.
microscopic detail with light, but maybe not seeing quite as deep.
That's a perfect way to put it. And OCT's unique power lies in unraveling that microstructure, identifying things like plaque rupture, plaque erosion, we'll get into those, and critically, measuring the thickness of the fibrous cap covering the plaque core, the FCT. This resolution is why cardiology guidelines, like those from the European Society of Cardiology, increasingly recommend using OCT when you're faced with ambiguous colpite lesions, or in situations like Minoka myocardial infarction with non-obstructive coronary arteries.
Minoka, where someone has a heart attack, but the standard angiogram doesn't show a major blockage.
Exactly. In those cases, you need OCT's resolution to find that tiny flaw, that subtle erosion or rupture that caused the big event.
And we also have technologies that try to combine these strengths, hybrid imaging.
Yes, and the most important one right now combines either IVUS or OCT with near-infrared spectroscopy, NIRS. NIRS is crucial because it's the only imaging technology that's specifically validated for the biochemical detection of lipid of fat within the vessel wall. It directly senses the chemical signature of cholesterol.
So it adds chemical information to the structural image.
Precisely. Combining NIRS with IVUS gives you volume and composition. Combining it with OCT gives you microstructure and composition. It's aiming for the best of multiple worlds, all collected during a single catheter pullback through the artery.
All right, this is where it gets really fascinating. We're moving into the chemistry and architecture of the plaque itself. It's one thing to see a lunk, but it's another to figure out if it's just harmless scaffolding or, a ticking time bomb. Let's start with the most infamous component, the lipid core and necrotic core, the fatty stuff.
This really is the heart of the vulnerability problem. The whole concept goes way back actually to the 19th century with Rudolf Virchow. He described the atheroma, that fatty mass, often liquefied, encapsulated by a fibrous cap. He recognized even then that this structure was inherently unstable, vulnerable to rupture. We're essentially using modern tech to find exactly what he described.
So if we're hunting for that fat, that lipid, which tool gives us the definitive answer? You mentioned NIRS.
That's NIRS. It's considered the gold standard specifically for lipid detection in vivo. It works by sending out specific wavelengths of near-infrared light that get absorbed by lipid molecules. Nothing else absorbs light quite the same way. The output isn't a structural image, but a chemical map called a chemogram. It color codes the probability of lipid being present at each point along the artery. Yellow typically means high probability of lipid, red means low probability.
Chemical heat map for fat.
Pretty much, yeah. And the key metric we derive from this is the lipid core burden index, or LCBI. Specifically, we look at the maximum LCBI value found within any 4 millimeter segment along the pullback. We call that the max LCBI 4 millimeter.
Why just 4 millimeters? Why that specific length?
Because plaque instability tends to be localized. It's not usually the whole plaque that's unstable, but a specific concentrated hotspot. We're looking for that dense collection of lipid packed into a short, critical segment. And the research, especially large studies, has established a critical threshold. A max LCBI 4 millimeter greater than 400 is highly indicative of a dangerous lipid-rich component. It's one of the strongest predictors of future events we currently have from imaging.
Okay, max LCBI 4 millimeter over 400 from NIRS means high-risk lipid. How does traditional ultrasound, IVUS, try to spot lipid without that chemical sensitivity?
IVUS has to infer it indirectly. Lipid-rich plaque tends to be softer and less dense than fibrous tissue, so on the IVUS image it appears darker, what we call hypoechogenic or echolucent. It doesn't reflect the sound waves as strongly. Now, there is some correlation with histology, but the big drawback, as the source material highlights, is the high inter-observer variability.
Meaning different doctors see different things.
Exactly. One experienced technician might look at a darkish area and call it lipid pool, while another might interpret the same image as just fibrofatty tissue, something less dangerous. That lack of consistent interpretation is a real limitation, and it's why NIRS, with its objective chemical signal, has been such a game changer for lipid assessment.
And what about that older IVUS-based technique, virtual histology IVUS or VHIVUS? That one created those color-coded maps, right? It looked like it was classifying tissue types.
Yes, VHIVUS was historically very important. It took the raw radiofrequency signal from the IVUS transducer and processed it to try and classify tissue into four main types, usually color-coded: fibrous green, fibrofatty, light green, necrotic core red, and dense calcium white. It allowed us, for the first time really, to define a fibrotheroma in vivo as a plaque containing, say, more than 10% confluent necrotic core, that red area. But VHIVUS ran into significant problems when it came to identifying the most critical lesion, the thin cap fibrotheroma, TCFA. This is the lesion type most prone to rupture. The original VHIVUS criteria for defining a TCFA were quite complex. It involved checking if the necrotic core, the red stuff, was touching the lumen over a certain arc initially more than 36 degrees and across several consecutive image frames. In the PREVENT study, they slightly adjusted this to 30 degrees.
Wait, 36 degrees of the circumference touching the lumen. That sounds like a really subtle finding and probably very dependent on the image quality and the processing algorithm.
It is subtle and incredibly challenging for consistent human analysis, and that really gets to the core issue. VHIVUS's axial resolution, its ability to distinguish depth accurately, just isn't good enough. It simply cannot reliably measure the single most important feature of a TCFA, the actual thickness of the fibrous cap, FCT, overlying the necrotic core. If you can't measure the cap thickness reliably, you can't confidently classify a TCFA versus a more stable, thick cap fibrotheroma. And that limitation is why VHIVUS usage has significantly decreased.
So VHIVUS can't measure the cap. We turn to the high-resolution champion, OCT.
OCT is absolutely the solution for measuring fibrous cap thickness. With its 15-micron resolution, it can clearly visualize the cap. In OCT, the lipid or necrotic core appears as a hyperreflective region. It shows up as a dark area because lipid doesn't reflect light well, and it typically has diffuse, fuzzy borders. This dark core is covered by the fibrous cap, which, being collagen-rich, appears very bright or hyperreflective. And the gold standard classification for vulnerability using OCT is the thin cap fibrotheroma, TCFA, defined by a fibrous cap thickness, FCT, measuring less than 65 micrometers.
Less than 65 microns. That's thinner than a human hair. Measuring that consistently must be tough.
It is incredibly demanding, which is why the source material strongly recommends using automated software for FCT measurement. When the difference between classifying a plaque as high risk versus stable comes down to a few microns, relying on automated, reproducible measurements is really essential for clinical decision-making and patient safety. Manual measurements are just too prone to variability.
Okay, so OCT nails the cap thickness. What about CCTA? Can it tell us anything about the lipid core?
CCTA gives us a rougher estimate using Hounsfield units, HU, which basically measure tissue density based on X-ray attenuation. Plaques that show up with a low density, typically below 30 HU, are classified as low attenuation plaques. And studies have shown these low attenuation areas statistically correlate pretty well with lipid-rich plaques identified by IVUS or NIRs. Sometimes CCTA might show a specific high-risk pattern called the napkin ring sign. This looks like a dark, low attenuation rim surrounding a central core. When you see that, it's often associated with a large lipid core. But again, it's an indirect sign, not a direct measurement like NIRS or OCT provides. #, B, calcium.
Okay, let's shift gears to calcium. Now, calcium itself doesn't usually cause the plaque to rupture, but its presence, its amount, and its pattern are critically important. Important for risk assessment and absolutely vital when planning an intervention like stenting.
Absolutely. And CCTA is usually the first place we look for calcium non-invasively.
Huh.
The standard assessment is the coronary artery calcium score, or CAC score, often using the Agatston method. Decades of research show the CAC score is a powerful, reliable predictor of future cardiovascular events, especially in asymptomatic people. A CAC score of 0 is very reassuring. It indicates extremely low risk.
But CCTA still has that resolution limitation we talked about. A 0 score isn't a guarantee.
Exactly. A 0 score doesn't mean there's absolutely no calcium or no plaque. The resolution limits mean very small calcium flecks or softer, non-calcified plaques might simply be missed. And at the other extreme, in patients with very heavy calcification, those blooming artifacts can become a real problem, making it hard to assess the underlying lumen or plaque composition accurately. But CCTA does look for a specific pattern called spotty calcification. This is defined as small, dense spots of calcium brighter than 130 HU, measuring less than 3 millimeters in size. Interestingly, these tiny spotty calcifications are strongly associated with vulnerable plaques found by IVUS. They might indicate a more active inflammatory process compared to large, solid sheets of calcium, which tend to be more stable.
Okay, now let's go back inside the artery with IVUS and OCT. How do they see calcium, given the sound versus light difference? How does IVUS handle it?
IVUS sees calcium very clearly. Because calcium is so dense, it reflects sound waves intensely. So it appears as a very bright, hyperechoic structure on the IVUS image. But, and this is a crucial limitation, the sound wave cannot penetrate through the dense calcium. When the ultrasound beam hits it, almost all the energy is reflected back, creating a dark area behind the calcium deposit. We call this acoustic shadowing. So IVUS is highly sensitive and specific. We're talking 90% to nearly 100% accuracy for simply detecting the presence of calcium. It sees it's there.
But because of that shadow, it can't tell you how much calcium there is.
Precisely. Since the sound beam gets blocked, IVUS can't measure the actual thickness or the area or the volume of the calcium deposit. It can usually measure the arc, how many degrees of the vessel circumference the calcium covers, but it can't tell you if it's a thin, superficial sheet or a deep, thick chunk. The shadowing just tells you it's dense enough to block sound. That's a major drawback if you're planning to put a stent there.
And this is where OCT, despite using light, which normally has less penetration, actually has a huge advantage for calcium specifically.
Exactly. It seems counterintuitive, but OCT often handles calcium better than IVUS in terms of quantification. OCT sees calcium as a hyporeflective area. It appears dark because calcium doesn't scatter light well, but crucially, it has sharply delineated clear borders. And the key advantage is that the near-infrared light used by OCT can actually penetrate through calcium in most cases, unless the calcium is exceptionally thick and dense. Because the light gets through, OCT allows us to perform a full quantitative assessment in 3 dimensions. We can measure the calcium's angle or arc in degrees, its length along the artery in millimeters, and critically, its thickness, also in millimeters.
And knowing the thickness is the game changer for planning an intervention.
It's non-negotiable. If you're planning a percutaneous coronary intervention or PCI placing a stent, you absolutely need that OCT data on calcium. If the OCT shows, for instance, calcium that's thicker than half a millimeter, 0.5 millimeter, and covers more than 180 degrees of the vessel circumference, you know before you even try to deliver a stent that you must use aggressive calcium modification tools. Things like rotational or orbital atherectomy, drilling or sanding the calcium, or intravascular lithotripsy, using sonic shock waves to crack it. If you try to just inflate a stent against that kind of calcium without preparing the vessel first, the stent simply will not expand properly. It will be underexpanded, maybe asymmetrically deformed, and that sets the patient up for stent failure down the road. The sources even mentioned that AI algorithms were already validated to predict the risk of stent underexpansion based purely on these pre-procedural OCT calcium measurements. It's that critical. Hashtag tag sexy. Other microstructures.
Beyond those major players, lipid and calcium, the incredible resolution of OCT lets us glimpse even smaller structures, the micro details that tell us about the biological activity happening inside the plaque. Let's touch on what these reveal.
Okay, we can start with the most common component, especially in earlier stages of disease: fibrous tissue. This is basically the collagen-rich scaffolding of the plaque. On IVUS, it looks fairly homogeneous and normoecogenic, kind of a neutral gray. On OCT, because collagen strongly reflects light, it appears very bright and hyperreflective.
All right. Now, what about signs of inflammation? That usually means macrophages, right? The immune cell.
Exactly. Macrophages are key inflammatory cells. They gobble up lipids, contributing to that necrotic core formation, and they release enzymes that can weaken the fibrous cap. So seeing them is a sign of active disease. On OCT, they typically appear as multiple bright reflective spots, often clustered together near the surface of the plaque. Sometimes, if they're densely packed, they can cause some shadowing behind them. Now, while OCT is pretty good at spotting macrophage accumulations near the lumen surface, detecting them deeper within the plaque is much harder. And honestly, even identifying them consistently is challenging for human observers. The source mentions that correlation between expert readers for macrophage identification is often only moderate to low.
So subjectivity creeps in again.
It does. And that's precisely why AI methods are being rapidly developed and deployed for this specific task. The hope is that AI can learn the subtle patterns and provide a more standardized, reproducible assessment of inflammatory activity based on macrophage signals.
Okay. What about the actual cholesterol itself when it crystallizes? That sounds like a bad sign.
It generally is. Cholesterol crystals are thought to physically disrupt plaque structure and trigger intense inflammation. And they show up quite vividly on OCT. They look like bright, linear, sharply defined structures, almost like little needles or shards of glass, often appearing stacked together. Crucially, they don't typically cause dorsal shadowing behind them, which helps distinguish them from microcalcifications. Compared to cystology, OCT has maybe low to moderate sensitivity for crystals. It might miss some, but when you do see them, the specificity is very high. Their presence is a strong indicator of a highly active, potentially unstable plaque core.
And we also hear about microvessels within plaques contributing to instability.
Yes, these are tiny, newly formed blood vessels called near vessels. They typically range from about 50 to 300 micrometers in diameter, so again, something only OCT can reliably resolve. They form within the thickened artery wall as the plaque grows. On OCT, they appear as small, well-demarcated signal pore voids, basically tiny black holes or channels within the plaque structure. To be confident as a microvessel, you need to see this void persist across at least 3 consecutive image frames as the catheter pulls back. Why are they important? Because these neovessels are often fragile, immature, and leaky. They're thought to be a major source of intraplaque hemorrhage, bleeding inside the plaque, which is a key driver of rapid plaque progression and necrotic core expansion.
Okay, and finally, the most acute finding, thrombus. The blood clot itself. I think you said OCT is unmatched here?
It is the undisputed gold standard for characterizing thrombus inside a coronary artery. Thanks to that 15-micron resolution, OCT can actually differentiate the likely composition of the clot based on its optical properties. We can classify thrombus into types. 1. Red thrombus. This type is rich in red blood cells, erythrocytes. It typically appears highly reflective on its surface but causes very sharp signal attenuation. Deeper down, it casts a definite shadow behind it. 2. White thrombus. This type is predominantly made of platelets. It tends to look more homogeneous and has low signal attenuation. It doesn't cast that strong shadow.
3. And of course, mixed thrombus, showing features of both.
And knowing red versus white thrombus actually matters clinically. It can. Red thrombus is often associated with plaque rupture in high-flow situations, leading to a large clot burden. White thrombus, on the other hand, is classically associated with a plaque erosion, where the clot forms more gradually on the plaque surface. IBUS and CCTA, with their lower resolution, simply cannot provide this level of chemical or structural differentiation. They can usually see that there's a clot, a heterogeneous mass sticking into the lumen, but they can't reliably tell you what kind it is. OCT gives us that crucial extra layer of information. So as you've heard, we now have this amazing ability to see and measure maybe half a dozen different high-risk features within a single plaque. The problem historically, though, is that everyone used slightly different names or criteria. One study's vulnerable plaque might be slightly different from another's. It wasn't systematic. This new proposal, discussed in the review, aims to fix that by creating a more standardized classification system, a common language.
And a key part of this new system seems to be acknowledging that risk isn't just about what type of plaque it is, but also how bad that plaque is in other ways.
Yeah.
Risk is cumulative. They simplify this with these L indicators, right?
Exactly. The proposed system highlights 3 key features, L1, L2, and L3, which are based on characteristics consistently proven to be high-risk predictors in major natural history studies, like the Prospect trial we'll discuss later.
Okay, let me try and nail these down for the listener. This is like the quick risk score overlay. L1, this is just too much plaque overall. Large plaque burden, specifically defined as greater than 70%. The sources call this the single strongest predictor of future trouble from that lesion. L2, this means too much fat, lipid-rich composition.
Yeah.
This can be defined either by seeing a large area of that dark hyperreflective tissue on OCT or IVUS, usually more than one quadrant OR by hitting that critical NRS threshold, max LVBI 4 millimeters greater than 400, and L3. This means the remaining opening is too small. Small lumen area, specifically a minimum lumen area, MLA, less than 4 square millimeters.
That's a perfect summary. Think of them as high-risk flags. And the idea in this new nomenclature is to add these L indicators as a suffix, using a plus "e" to the underlying plaque type. So a cardiologist reading an imaging report wouldn't just see fibrotheroma, they might see fibrotheroma plus L1 plus L3.
Ah, so that instantly tells them, okay, this is a fatty plaque, fibrotheroma, and it's also really extensive L1, and it's already causing significant narrowing L3.
Much more informative.
Precisely. It provides an immediate standardized risk stratification right there in the name.
Okay, so using this system, let's quickly run through the main plaque types, starting with the ones that haven't ruptured yet, the non-complicated plaques. Right. These are plaques that might be stable or potentially progressing but haven't caused an acute event. Pathological intimal thickening, PIT. This is often the earliest stage, mostly just fibrous tissue thickening the wall, relatively stable. If it gets big enough to cause narrowing, you might label it PIT plus L3, fibrotheroma, FA. Now we have a definite lipid core mixed in with the fibrous tissue. By definition, FAs are lipid-rich, so L2 might apply depending on the extent. This represents a more advanced stage than PIT, kind of progressing towards vulnerability. Thin cap fibrotheroma, TCFA, this is the classic vulnerable plaque. It's a fibrotheroma where that overlying fibrous cap is dangerously thin, less than 65 millimeters as measured by OCT. The risk of rupture increases significantly as you go from PIT through a thick cap fibrotheroma, THCFA, where the cap is thicker than 65 millimeters, to the TCFA. If a TCFA is also very large, it would be labeled TCFA plus L1, fibrocalcific FEC. This is basically a mixed plaque where dense calcium is a major component, covering perhaps more than one quadrant of the circumference. Hashtag be complicated. And thrombus-associated lesions.
Okay, now for the lesions that are actively causing trouble, the ones presenting as heart attacks or acute syndromes. The most common culprit is plaque rupture.
Yes, plaque rupture, PR, is the textbook cause, responsible for something like 2/3 of acute coronary syndromes, ACS. On imaging, particularly OCT, PR is defined by a clear break or tear in the fibrous cap, creating a cavity or ulceration within the plaque that directly communicates with the flowing blood in the lumen. Statistically, PR is found much more often in AMI patients, around 66%, compared to patients with stable angina, around 27%. The challenge, though, even for high-res OCT, is that when a rupture happens, a blood clot thrombus often forms almost instantly and fills that cavity. This thrombus can sometimes obscure the actual site of the tear, making definitive diagnosis tricky in some cases, but usually the combination of a visible cavity plus overlying thrombus is strong evidence for PR.
Got it. Next up is plaque erosion, PE. This one sounds fundamentally different because the key is that it's a clot forming without that cap rupture. And you said this is maybe more common in younger patients.
That's right. PE is a really fascinating and increasingly recognized entity. Pathologically, it's thought to involve the loss or damage of the very thin layer of endothelial cells lining the artery, occurring over a plaque that is often rich in smooth muscle cells and might not have a large necrotic core like a typical fibrotheroma. It seems less about a mechanical failure of the cap and maybe more about some biological process happening right at the surface. The big problem for imaging, though, is that even OCT, with its amazing resolution, cannot visualize the single layer of endothelial cells. We just can't see them.
So if you can't see the missing endothelial cells, the OCT definition has to be indirect, based on what it doesn't see.
Exactly. It's a diagnosis based on exclusion, primarily. The working clinical definition is evidence of thrombus attached to the plaque surface, but UT without any visible sign of fibrous cap disruption, no tear, no cavity. A&D provided that you've reasonably ruled out the possibility that the clot came from somewhere else, coronary embolism. On OCT, this typically looks like thrombus, often that platelet-rich white thrombus we discussed sitting on an apparently intact plaque surface.
But you flagged this earlier as being controversial. Why the controversy if the definition seems clear? Is it about potential damage during the procedure itself?
That's precisely the issue. Imagine a patient comes in having a heart attack. Standard procedure might involve passing a catheter up to the blockage, maybe even using an aspiration catheter to suck out some of the clot before we do the imaging. Now, that catheter passing over the plaque surface, especially if the cap was maybe borderline thin to begin with, could potentially cause an iatrogenic disruption, a tear caused by the procedure itself. Then, when we do the OCT, we see a tear and thrombus, and we might incorrectly call it a spontaneous plaque rupture, when maybe it started as an erosion that got disrupted by our intervention.
Or the other way around. You might miss a subtle rupture hidden under clot.
Or you might aspirate clot off an erosion and think the surface looks fine, maybe missing subtle damage. This inability to be 100% certain whether the disruption was spontaneous or procedure-related makes the diagnosis challenging to standardize perfectly. And this uncertainty is really important when we talk later about trials looking at not stenting plaque erosion, because the accuracy of the initial diagnosis is paramount.
Makes sense. Okay, moving on to eruptive calcified nodules, ECNs. These sound pretty dramatic, like sharp rocks bursting out.
They are quite aggressive looking. An ECN is defined by a chunk or nodule of calcium located very superficially right near the lumen that is actively protruding or erupting into the bloodstream. Critically, this eruption is associated with disruption of the overlying fibrous cap and usually has thrombus attached. The term eruptive specifically means it's complicated, it's causing the acute event. On IVUS, you might see it as an irregular, convex bulge of bright calcium pushing into the lumen. If you see a similarly protruding calcified nodule, but the overlying fibrous cap appears intact, then it's classified as a non-eruptive calcified nodule, considered more of an innocent bystander lesion, not the acute culprit.
All right. And lastly, there's this idea of intraplaque hemorrhage, IPH, bleeding inside the plaque itself. Sounds like it makes things worse.
Pathologically, IPH is considered a major driver of plaque progression. When those leaky neovessels bleed into the plaque, the red blood cells break down, releasing free cholesterol and inflammatory components. This rapidly expands the necrotic core and can destabilize the plaque. Diagnosing it reliably with imaging is still tough. The proposed definition is looking for a hyporeflective, dark on OCT, or hypoechogenic, dark on IVUS core area that doesn't cause significant signal attenuation or shadowing behind it, distinguishing it from dense calcium or maybe certain types of thrombus. Recognition is still challenging, the source material says, but finding evidence of IPH generally signifies more advanced, complex atherosclerosis and likely a higher risk for future progression or events.
Okay, this section is really where the rubber meets the road for you, the listener. We've seen all this incredible detail imaging can provide. Now, the crucial question, which of these features actually tells us which plaque is likely to cause a clinical event down the line? We're moving from just describing plaques to trying to predict the future.
And a lot of the foundational work on prediction came from those earlier IVUS studies back in the early 2000s. Landmark trials like Prospect, Viva, and Atheromemo Ivis were really instrumental. They consistently showed a clear link. Coronary lesions that were not the original culprit for the patient's admission, but which possessed those high-risk L indicator features we talked about, particularly high plaque burden, L1, evidence of being lipid-rich, L2, based on IVUS appearance then, and having a small minimum lumen area, L3. These lesions were associated with a significantly higher risk of causing future major adverse cardiac events, MAC, like a heart attack or needing urgent revascularization.
The findings were consistent across studies, you said. Yet you also mentioned earlier there was significant skepticism in the cardiology community about actually using IVUS routinely for risk stratification based on these findings. If the data was consistent, why the hesitation?
It really came down to the numbers, specifically the positive predictive value, or PPV. While these features were consistently associated with future events, the PPV of these IVUS-derived characteristics for predicting an event in any specific lesion remained stubbornly low. It hovered around only 18% to 24% in these major studies.
18 to 24%. So if you found, say, 5 plaques that met the high-risk IVUS criteria.
Exactly. On average, only one of those 5 lesions would actually go on to cause a clinical event within the next few years. The other 4, despite looking risky on IVUS, would remain quiescent. And you can see the clinical dilemma. Is it worth performing an invasive IVUS procedure with its costs and small risks just to identify markers that have roughly an 80% chance of being a false positive for predicting an event in that specific spot? Many clinicians felt the predictive yield just wasn't high enough to justify widespread screening of non-culprit lesions with IVUS alone. We needed better, more specific markers of vulnerability.
And that need for better markers led the focus towards composition, specifically lipid, using NIRS.
Precisely. The hypothesis was maybe the problem wasn't just size, plaque burden, or narrowing MLA, but the actual chemistry of the plaque. NIRS provided that direct chemical confirmation of the lipid core. The atheromemo study was an early important signal. It showed that having a large lipid component, as detected by NIRS, increased the risk of subsequent adverse events by about 4-fold. But the real confirmation came from the LRP study, which stood for Lipid-Rich Plaque Study. LRP was a large study, over 1,500 patients, and it definitively established that having a higher maximum LCBI 4 mm, that measure of concentrated lipid from NRS, was an independent predictor of NE. When they looked specifically at events originating from individual lesions, the risk ratio was significantly elevated, about 1.89 for lesions with a high max LCBI 4 mm. It really solidified that lipid concentration itself is a powerful prognostic factor.
And this finding was then validated in that big follow-up study to the original Prospect trial.
Absolutely. Prospect 2 was another landmark trial, building directly on LRP. They enrolled patients admitted with ACS, performed 3-vessel angiography, and then used combined NRS IVUS imaging to examine all the non-culprit arteries. And it confirmed the findings beautifully. Lesions that combined both a large lipid core, high LCBI, or L2, and an increased plaque burden, high PB, or L1, were the ones that led to alarmingly high event rates down the road. In those doubly high-risk lesions, the 4-year rate of MACE specifically related to those non-culprit plaques was 13.2%. That's a very significant risk originating from lesions that weren't causing problems initially. It really cemented the value of combining volumetric IVUS and compositional NRS assessment.
Okay, so NIRS added crucial predictive power by confirming lipid. Now let's bring in OCT. Its strength is microstructure, especially that fibrous cap. Did OCT studies provide similar prognostic insights?
They did, providing equally powerful but complementary data. The focus with OCT shifted more towards the structural integrity, particularly the cap thickness. The CLAIMA study was a large observational registry following over 1,000 patients with OCT imaging. They looked for a convergence of multiple high-risk OCT features in non-culprit lesions. They found that when lesions possessed a combination of 4 specific characteristics, a small MLA, less than 3.5 millimeter and similar to L3, a large lipid arc, more than 180 degrees, definite TCFA status, meaning FCT less than 75 millimeters in their definition, and the presence of macrophages, indicating inflammation, patients harboring such lesions faced a really high 18.9% event rate at just 1-year follow-up. That convergence of factors identified a very high-risk subset.
Almost a 1 in 5 chance of an event within a year. Wow. And there was another key OCT trial focusing on diabetic patients.
Yes, the Combine OCT FFR trial. This one was particularly revealing because it focused on patients with diabetes who are known to have more diffuse and vulnerable coronary disease. But critically, they looked only at lesions that were non-flow limiting.
Meaning lesions where the fractional flow reserve, or FFR, the measure of blood flow restriction, was actually normal. FFR greater than 0.80.
Exactly. These were lesions that, based on standard physiological assessment and current guidelines, you would generally treat only with medication because they weren't significantly impeding blood flow.
So functionally innocent lesions.
Functionally innocent, yes, but morphologically. The study found that even among these non-flow limiting lesions, if OCT identified the presence of a TCFA phenotype, thin cap lipid core, those lesions still predicted a high rate of MAC 13.3% over the follow-up period. This was compared to only a 3.1% event rate in lesions with other morphologies but similarly normal FFR.
That's a huge difference. What's the implication?
It was a major paradigm shift. Combine OCT FFR strongly suggested that plaque morphology, its structure, its vulnerability as seen by OCT, can predict future events independently of its functional severity, its impact on blood flow. It meant that a plaque could look safe from a flow perspective but still be dangerous because of its underlying structure. This finding really fueled the debate about preemptive treatment.
And that leads us right into perhaps the most challenging clinical and ethical question in this field right now. If our imaging is getting so good that we can identify these non-flow limiting plaques that have a high statistical chance of rupturing in the next few years, should we intervene on them now? Should we put in a stent preemptively to prevent that future heart attack, or should we rely on optimizing medical therapy?
That is the multi-million-dollar question, and it was the exact question addressed by the PREVENT trial. This study was truly groundbreaking because it specifically took patients who were identified using intracoronary imaging as having these high-risk, vulnerable plaques. But importantly, these plaques were confirmed to be non-flow limiting with an FFR greater than 0.80.
How did they define high risk or vulnerable in PREVENT? It must have been pretty strict to justify randomizing to stenting.
It was extremely rigorous. To even be eligible, a patient's non-flow limiting lesion had to meet at least 2 out of 4 very specific high-risk criteria derived from combined IVUS and NIR imaging. The criteria were either the large plaque burden, L1, PB 70%, the small lumen area, L3, MLA 4.0 millimeter better, high lipid content confirmed by NIRS, max LCBI 4 millimeter 315 in their protocol, or having a definite TCFA based on VH-IVUS criteria at the time, though OCT would likely be used now. If a lesion met 2 or more of these criteria, the patient was then randomized to either receive prophylactic PCI, meaning getting a stent placed in that vulnerable spot, plus optimal medical therapy, OMT, or they received OMT alone, the current standard of care.
Okay, so a head-to-head comparison, preemptive stenting versus best medical treatment. What were the results?
The results, presented relatively recently, were highly provocative, generating a lot of discussion. At 2 years of follow-up, the primary outcome, which was target vessel failure, a composite of cardiac death, target vessel myocardial infarction, or clinically driven target vessel revascularization, occurred in 3.4% of the group that received OMT alone.
Okay, 3.4%. And the group that got the preemptive stent.
In the preventive PCI group, the rate was only 0.4%.
0.4%. That's almost tenfold reduction, an almost complete elimination of events related to that vessel in the group that got the stent. That sounds like a massive win for preemptive treatment.
On the surface, it looks like a very strong signal, yes. It strongly suggests that identifying these high-risk, non-flow limiting lesions and treating them locally with a stent can indeed prevent future events originating from that specific spot. But, and this is a crucial but raised by the authors and commentators, we need to be cautious about interpreting this. Firstly, implementing this approach globally would require performing comprehensive screening, likely 3-vessel FFR, and advanced invasive imaging like NIRS, IVUS, or OCT on a huge number of patients to find these relatively uncommon high-risk lesions. That has massive implications for resources, cost, and procedural risk. Secondly, while the reduction in target vessel failure was dramatic, we need longer-term follow-up to be absolutely sure that the events prevented were truly major events like heart attacks, and that the benefit persists without unforeseen long-term issues related to the prophylactic stent itself.
So the data is exciting, strongly suggestive, but maybe not quite ready to change global practice guidelines tomorrow.
That's the general feeling. PREVENT provides compelling proof of concept that targeted intervention can work for these lesions, but we're not quite at the stage of recommending universal screening and preemptive stenting based on this one trial. We need more data.
But the research isn't stopping there. Other trials are following up on this.
Absolutely. The source material mentions several ongoing randomized trials like INTERCLIMA, Combine Intervene, and Vulnerable, which are specifically designed to further explore the long-term clinical benefit and safety of this preemptive invasive treatment strategy for high-risk, non-flow limiting plaques. The field is definitely moving in this direction, trying to confirm and refine the PREVENT findings. #tag tailoring treatment for acute coronary syndromes, ECS culprits.
Okay, let's shift from preventing future events to the acute setting. A patient comes in now with a heart attack or unstable angina. How does our ability to image the actual culprit lesion, the one causing the problem right now, help guide treatment decisions and maybe predict outcomes?
It provides really valuable information. Let's take plaque rupture, PR, the most common cause. The standard treatment is immediate PCI with a drug-eluting stent, DES. That's unlikely to change. However, OCT imaging done before the stent goes in can provide prognostic information. Studies referenced in the review have shown that patients whose culprit lesion was confirmed by OCT to be a PR actually had a somewhat poorer prognosis after successful stenting. They had a higher risk of recurrent unstable angina or needing repeat revascularization later on compared to patients whose ACS was caused by other lesion types like erosion. So, knowing it was a rupture flags the patient as potentially higher risk, even post-PCI.
Interesting. But the really hot debate right now seems to be around plaque erosion, PE. Since the cap is intact, can we potentially avoid putting in a permanent metal stent altogether?
That's the critical question driving a lot of research. As we discussed, PE patients often tend to be younger. They might have less severe underlying stenosis and often less thrombus burden compared to PR patients. Non-STEMI is a common presentation. Since the underlying structure might be more stable, the hypothesis emerged. Could we just use intensive antithrombotic medications, strong blood thinners, to dissolve the clot and allow the damaged endothelial surface to heal, thereby avoiding the need for a stent and its potential long-term complications, like stent thrombosis or restenosis?
Where did the initial evidence for this non-stenting approach come from?
The pioneering work came from the erosion IN2 studies. These were prospective, single-arm studies, not randomized. They carefully selected patients presenting with ACS who had OCT confirmation of plaque erosion as the culprit and who had reasonably good blood flow restored, TMI 3 flow, and residual stenosis less than 70% after initial management, like thrombus aspiration. These selected patients were treated with dual antiplatelet therapy, usually aspirin and ticagrelor, without stenting. The results were quite encouraging. They found that the thrombus volume decreased significantly over time, and the primary endpoint, achieving at least 50% thrombus volume reduction at 1 month, was met in about 78% of patients. Many patients had near complete resolution over a year.
Okay, promising observational data. Did that lead to a randomized trial?
It did. The Erosion 3 trial took the next logical step. It randomized patients presenting with STEMI, a more acute type of heart attack, to either OCT-guided reperfusion strategy or a standard angiography-guided strategy. The primary goal was to see if using OCT to identify PE and potentially defer stenting could safely reduce the overall rate of stent implantation. And the results showed that it could. The OCT-guided arm had a significantly lower rate of stenting compared to the angiography-only arm, around 44% stented versus 59%. Importantly, despite less stenting in the OCT arm, the major clinical outcomes, a composite of cardiovascular events, were comparable between the two groups at 1 year.
So, less metal in the artery, same patient outcomes. That sounds like a win for the OCT-guided conservative strategy. What's holding it back from becoming the standard of care for erosion today?
The authors of the review echo the general consensus here. While the erosion studies provide very promising proof of concept, the evidence base is not yet considered robust enough to fundamentally change the established clinical practice guidelines for managing ACS, which currently recommends stenting for almost all culprit lesions. We still need larger randomized trials with longer-term follow-up to definitively prove the safety and non-inferiority of a non-stenting strategy compared to routine stenting for OCT-diagnosed PE. Until those trials report, stenting remains the standard, but OCT has clearly identified a patient subgroup where a less invasive approach might be feasible and beneficial in the future. The door is open.
Got it. We also need to touch on those eruptive calcified nodules, ECNs. You said they present a unique mechanical challenge.
They really do. ECNs are found in maybe 5% to 10% of ACS patients. Unfortunately, intervening on them tends to lead to poorer results compared to intervening on other plaque types, even other calcified plaques. That protruding, irregular, rock-hard nodule makes everything difficult. It's hard to deliver balloons and stents past it, and it's extremely difficult to get a stent to expand fully and evenly against it. These cases often require the most aggressive calcium modification techniques. We have orbital atherectomy, rotational atherectomy, lithotripsy often used in combination, just to prepare the vessel for stenting. They are among the toughest lesions to treat successfully.
And finally, the sources mentioned this potentially new category, superficial calcific sheets. This sounded really surprising, almost counterintuitive as a culprit.
It absolutely was a surprising finding from recent large OCT analyses. One study found that these superficial sheets were actually the most frequent type of calcified plaque causing ACS, accounting for maybe 2/3 of all calcified culprits in their cohort. What's so baffling about them is that on OCT, they often showed only minimal disruption of the overlying fibrous tissue. They didn't look grossly ruptured like a PR or necessarily eroded like a PE. Yet, these lesions were associated with the highest rise in cardiac biomarkers indicating heart muscle damage after stenting.
Hold on. So a plaque that looks relatively intact on the surface causes an acute event and shows the most biological distress after treatment. That seems to completely challenge our simple rupture erosion model.
It really does. It suggests there might be another mechanism at play for these sheet-like calcifications. Perhaps microfractures within the calcium sheet itself, which aren't easily visible, trigger the clotting cascade. Or maybe the inflammation associated with the sheet leads to endothelial dysfunction and thrombosis without overt rupture. Honestly, the pathophysiology is still elusive, as the source points out. We desperately need detailed histological studies correlating with these OCT findings to understand how these superficial calcific sheets actually cause acute events. But their identification is a clear reminder that plaque biology and mechanics are far more complex than our previous neat categories allowed for. Nature keeps throwing us curveballs.
Okay, let's shift focus now to how imaging helps us track whether our medical treatments are working. The ultimate goal of therapy, beyond just preventing events, is ideally to halt or even reverse the disease process, plaque regression. Historically, IVUS was the main tool for this, right? Looking at plaque volume changes over time.
Yes, for many years, IVUS was the workhorse for serial imaging in clinical trials, testing lipid-lowering drugs or other therapies. Its ability to measure plaque volume reliably allowed us to track progression or regression over months or years. The main endpoints used were typically percentage atheroma volume, PAV, that plaque burden measure we discussed, or sometimes total atheroma volume, TAV. And the most compelling evidence for regression using IVUS came from the statin trials.
Right, the high-intensity statin trials. Those were pivotal, weren't they?
Absolutely pivotal. Large trials like Reversal, Asteroid, and Saturn provided definitive proof. They showed that using high-intensity statins, typically a atorvastatin 80 mg or rosuvastatin 40 mg, didn't just slow down plaque progression compared to lower doses or older drugs, but could actually induce statistically significant plaque regression. The plaques got measurably smaller on average. The Saturn trial was particularly interesting. It directly compared high-dose atorvastatin versus high-dose rosuvastatin. Rosuvastatin lowered LDL cholesterol levels even more profoundly than atorvastatin in that study. Yet, perhaps surprisingly, the actual amount of plaque volume regression measured by IVUS was very similar between the two groups.
So maximum LDL lowering didn't necessarily translate into proportionally more shrinkage.
Not in Saturn, based on the primary IVUS endpoint. It's suggesting maybe there's a threshold effect or other factors beyond just LDL levels influence volumetric change. But it's also important to keep the magnitude in perspective. The sources are careful to note that even with the most aggressive statin therapy, the actual amount of regression observed in these IVUS trials was typically very small, often less than a 1% absolute reduction in PAV over a year or two. Statistically significant, yes, but biologically modest. And attempts to boost this regression by adding other agents to statins, like ezetimibe B in trials such as Heaven and Zesus, generally fail to show any significant additional plaque regression effect based on these primary IVUS volume endpoints.
Okay, so statins cause slight regression. But the story changed quite a bit with the next class of major lipid-lowering drugs, the PCSK9 inhibitors.
It really did. The PCSK9 inhibitors, drugs like evolocumab and alirocumab, provide much more potent LDL cholesterol reduction than even high-intensity statins alone. When these were added on top of maximal statin therapy in clinical trials with IVUS endpoints, the results were consistently impressive. Trials like Giligov and Huygens using evolocumab consistently showed significantly greater plaque volume regression compared to statins alone. And more recently, the Pacman-AME trial showed that adding alirocumab to statins in patients after a heart attack caused significant plaque regression in the non-infarct-related arteries, the bystander vessels. So the potent LDL lowering translated into greater shrinkage.
What about drugs targeting other pathways? Inflammation, HDL, blood pressure. Did IVUS show benefits there?
The results there have been much more mixed, often disappointing. Some early studies on ApoAI Milano infusions aimed at raising HDL showed promise with IVUS, but larger trials of similar agents didn't pan out clinically. Among anti-diabetic drugs, the thiazolidinedionepioglitazone showed some reduction in plaque size in the Periscope trial, but another drug in the same class, rosiglitazone, didn't fare better than the standard sulfonylurea in approach. For antihypertensives, again, inconsistent. Amlodipine in Camelot showed maybe a non-significant trend towards less progression, while olmesartan in Olivis did show a decrease in plaque size. So the overwhelming message from the IVUS regression era, as summarized in the review, is that intensive LDL cholesterol lowering, especially achieving very low levels with statin plus PCSK9 inhibitor combinations, is the most potent and reliable driver of measurable volumetric plaque regression. #BOCT trials focus on FCT and lipid arc.
Okay, so IVUS showed us we could shrink the plaque volume, albeit modestly with statins, more so with PCSK9 inhibitors. But if the real clinical danger is plaque rupture, maybe shrinking the volume isn't the most important goal. Did the focus shift when OCT became available for these trials? Shift from volume to stability?
Absolutely, that's exactly what happened. Once OCT provided that unprecedented resolution to see the fibrous cap, the research focus shifted dramatically. The question became, can our therapies not just shrink the plaque, but actually reinforce its structure? Can we make it less vulnerable? So we moved from primarily volumetric endpoints like PAV to morphological stabilization endpoints, with the most important being fibrous cap thickness, FCT. Can we thicken that cap?
And what did the OCT trials show regarding statins and cap thickness?
The results were very encouraging and provided a new mechanism for statin benefit beyond just LDL lowering. A pooled analysis or meta-analysis of several OCT studies, mentioned in the review, confirmed that statin therapy consistently and significantly increased FCT by an average of around 67-68 micrometers. So statins aren't just potentially shrinking the lipid core, they seem to be actively promoting healing and thickening of the protective fibrous cap overlying it. They reinforce the shield.
Wow. And was there a specific trial that really demonstrated this stabilizing effect visually?
Yes, the IB-SWORD trial was quite compelling. It used high-dose rosuvastatin, 40 milligram, and performed serial OCT imaging. They documented a significant increase in the minimum FCT over the study period, but perhaps even more strikingly, they looked at the lesions that were classified as TCFAs, thin cap fibrothromas, FCT 65 millimeters at the beginning of the study. After about 13 months of high-intensity statin therapy, they found that nearly 70%, 69.2% to be exact, of those initially high-risk TCFAs had regressed morphologically, meaning their caps had thickened to the point where they no longer met the definition of a TCFA.
So the statin therapy effectively converted a high-risk plaque into a lower-risk, thick-capped plaque.
Exactly. That's the very definition of plaque stabilization. Thickening the cap beyond that critical 65 micron threshold makes it much less susceptible to mechanical stress and rupture. IBS-4 provided beautiful visual evidence of this healing process induced by statins.
Okay, so statins stabilize the cap. Now, what happens when you add the PCSK9 inhibitors on top? Do you get even more stabilization benefit, mirroring the volumetric benefit seen with IVUS?
The OCT data suggests, yes, absolutely. The results have been remarkably consistent across multiple trials that added a PCSK9 inhibitor, either alirocumab or evolocumab, to background high-intensity statin therapy and used OCT endpoints. Trials like Altair, Huygens, and again, PAC-MAN-AMI, which used multimodality imaging. All of these studies demonstrated that the combination therapy statin plus PCSK9 inhibitor induced a significantly greater increase in the minimum FCT compared to statin therapy alone. They also typically showed greater reductions in other markers of vulnerability seen on OCT, like the maximum lipid arc, a measure of circumferential lipid extent, and the macrophage index, a measure of inflammation.
Can you give an example of the magnitude, like in PAC-MAN-AMI?
Yes, PAC-MAN and MAMI provided very clear numbers. The average increase in minimum FCT over the 1U study was substantially greater in the group receiving alirocumab on top of statins, around 63 millimeter increase, compared to the group receiving placebo plus statins, around 33 millimeter increase. Almost double the cap thickening effect. So the overall conclusion from both IVUS and OCT regression trials is quite clear. Achieving maximal LDL-C reduction, typically with combination statin plus PCSK9 inhibitor therapy, appears to deliver the best of both worlds. You get greater volumetric regression, plaque shrinkage seen on IVUS, and superior morphological stabilization. Cap thickening, lipid reduction, inflammation reduction seen on OCT. This combination maximizes the chances of transforming dangerous, vulnerable plaques into safer, more stable ones.
We spent a good chunk of time now talking about measurements on the scale of micrometers, 65 microns for cap thickness, classifying thrombus types based on subtle optical properties, trying to identify clusters of inflammatory cells. Honestly, relying on human eyeballs and maybe manual calipers for this level of granular detail sounds incredibly challenging. Highly susceptible to fatigue, subjectivity, inter-observer differences.
You have absolutely hit the nail on the head. That variability, both intra-observer, same person measuring differently at different times, and inter-observer, different people getting different results from the same image, is arguably the single biggest bottleneck limiting the widespread, standardized clinical application of these incredibly sophisticated imaging diagnostics. It introduces uncertainty. And this is precisely the problem that artificial intelligence, AI, particularly machine learning, ML, and deep learning, DL models, is perfectly suited to address.
So AI here isn't just about doing things faster, it's about doing them more consistently, taking the human subjectivity out of the loop.
Exactly. Consistency and reproducibility are the primary goals. AI algorithms, once properly trained, can analyze these complex images using the exact same criteria every single time, eliminating human bias and variability. The promise is to standardize and significantly enhance this entire analytical process. Deep learning models, especially those using convolutional neural networks, CNNs, have proven to be state-of-the-art for tasks like image segmentation.
Segmentation meaning teaching the computer to draw the lines.
Essentially, yes. Teaching the machine to accurately identify and delineate the key structures, the lumen border, the outer vessel wall, EEM, and perhaps most importantly, the boundaries between different plaque components like lipid, calcium, and fibrous tissue. Once these structures are accurately segmented by the AI, then the calculation of things like plaque burden, lumen area, calcium volume, fibrous cap thickness, all those metrics we've discussed becomes automated, objective, and highly reproducible.
What are some specific areas where AI or ML has already shown real promise or success in coronary imaging, according to the review?
The review highlights several exciting applications where AI is already making inroads. 1. Automated quantification. AI is being used to automate many of the time-consuming but crucial measurement tasks. Things like automatically calculating the Agatston calcium score from CCTA, measuring the arc and thickness of calcium from OCT, or calculating the total atheroma volume from an entire IVUS pullback. This frees up physician time and ensures consistency. 2. Multimodality integration and classification. This is really powerful. Sophisticated ML models are being trained to predict high-risk lesion types, like TCFAs, by integrating data from multiple imaging modalities simultaneously. For example, combining the volumetric data from IVUS with the microstructural detail from OCT within the same algorithm. The idea is that AI can potentially extract more predictive information by fusing these complementary datasets than we could from looking at each image type alone. 3. Risk prediction beyond the lumen, radiomics. This is perhaps one of the most fascinating frontiers. AI, particularly deep learning, can analyze CCTA images and extract subtle textural patterns or radiomic features, not just from the plaque itself, but even from the perovascular adipose tissue, the fatty tissue surrounding the coronary artery.
Wait, the fat around the artery tells us about risk inside the artery.
It seems so. These AI-derived signatures from the perivascular fat appear to reflect local vascular inflammation. And studies are showing that incorporating these radiomic features can actually improve cardiac risk prediction over and above traditional factors like stenosis severity or even the calcium score. It suggests AI can help us quantify a systemic or paracrine inflammatory risk factor that we previously didn't know how to measure non-invasively.
So the potential is really huge. If the AI is trained properly on large, well-curated data sets, it could essentially take the guesswork out of measuring that 65 micrometer cap or classifying thrombus, making the whole diagnostic process much more robust and clinically reliable.
That's exactly the vision. The caveat, as always with AI, is the training. The source makes the important point. A badly trained AI algorithm can be just as bad, or maybe even worse, than a poorly trained physician, generating inaccurate or misleading results. Rigorous training, validation on diverse data sets, and ongoing quality control are absolutely essential. But when properly developed and validated, AI holds immense promise to standardize the incredibly sophisticated morphological analysis that modern coronary imaging enables. It could pave the way for truly personalized risk assessment and more precise, tailored therapies for atherosclerotic disease in the future. Hashtag tag out outro.
So if we try to synthesize everything we've discussed today, it's clear that intravascular imaging has fundamentally changed how we understand and evaluate coronary atherosclerosis. We've truly moved beyond just looking at silhouettes of narrowings on an angiogram.
We can now directly visualize the plaque itself, characterize its components, and identify specific features associated with high-risk capilloments. Those L indicators, L1 for high burden, L2 for lipid richness, L3 for small lumen, the NIRS-defined high lipid core, max LCBI 4mm 400, and especially the OCT-defined thin fibrous cap, TCFA FCT 65mm. Having the ability to pinpoint these provides powerful prognostic information. And importantly, we've also seen compelling evidence, particularly from OCT trials, that our best medical therapies, especially high-intensity statins and PCSK9 inhibitors, don't just lower cholesterol, but actively stabilize these vulnerable plaques by thickening the fibrous cap. Plus, technologies like OCT are already enabling exploration of potentially less invasive treatment strategies for specific culprit lesions like plaque erosion.
Which brings us right back to that core tension, that unresolved question facing the field. And the final thought we want to leave you, the listener, with today. Given the clear, consistent success of intensive medical therapy, especially the statin plus PCSK9 inhibitor combination in promoting systemic plaque stabilization and increasing fibrous cap thickness throughout the coronary arteries, and given the emerging, though still preliminary, evidence that more conservative, non-stenting strategies might be feasible and safe for certain lesions like plaque erosion, how will future treatment algorithms ultimately balance these two approaches? How do we weigh the proven benefits of widespread systemic medical regression against the potentially high-impact but much more localized and resource-intensive benefit of preemptive device treatment, like in PREVENT, for specific non-flow-limiting lesions identified by advanced imaging? Are we heading towards primarily systemic healing driven by powerful drugs, or towards more targeted prophylactic interventions guided by ever-improving imaging, or perhaps most likely some kind of precise, individualized marriage of both, orchestrated by the micro-level detail provided by AI-enhanced imaging? That's the complex future we're navigating. Thank you for watching The Funnel Effect.